It's about time to start. Good morning, everyone. It's really, I'm very happy to see you all again. Alan is over there, right? And it's after last, 2 years, 3 years, a pandemic. Actually, we have a lot of, changes and disasters. However, today, I'm very happy to meet old friends and you all here again. So this is the fourth session, and maybe we have our opening tomorrow morning. So this is the fourth session of our TCTAP 2023. Very happy to see you again. So I would introduce Mamas from England, our co-chair, and many distinguished panels here. Ali, Ziad Ali here, Goel, Dr. Goel, Jafary, Dimitrios is here, right? Yes. Here. Oh, good to see you. And so Dr. Kim Byeong-Keuk, I'm here. Louvard is old friend, Sachona Nakamura is here. So, okay, Mamas. Introduce.
So thank you. It's always a pleasure to be here, and it's a great meeting. So looking forward to this interesting session. If I'd like to ask David Cohen, a man that needs no introduction, to talk about left main revascularization consensus gaps in 2023. So David, over to you.
Well, thank you very much, Mamas and SJ. It's really a pleasure to be back, and it's wonderful to see so many old friends and hopefully meet more new friends. So I was asked to kick this off by talking about revascularization for left main disease and what we know and what we need to know. These are my disclosures. So this has been a somewhat controversial topic over the last 5 years or so. These are just some headlines of news articles discussing some of the debates between the surgical societies and the medical societies. But I think I'm hoping I can bring a little consensus to this. So let's look at what the guidelines actually say that we have currently. So the ESC guidelines say we should revascularize patients with left main disease of greater than 50%. And in terms of the types of revascularization, bypass surgery has a level 1A recommendation for all different severities of associated coronary disease, whereas with PCI, it's a graded recommendation. It's 1A for patients with low syntax score, 2A for patients with intermediate syntax score, and 3 for patients with very complex disease. The American guidelines are a little bit different, but fairly similar. So they say that in patients with significant left main stenosis and stable disease, CABG improves survival. And then in selected patients with stable ischemic heart disease and left main disease, where comparable levels of revascularization are comparable, then PCI is also reasonable to improve survival. So a little bit, again, of a graded recommendation. So the 3 areas I want to cover very briefly here that are unresolved or questions still in the field is whether bypass surgery should really be the preferred therapy for most patients, whether there's a role for mechanical circulatory support, and briefly on 1 versus 2 stent strategies. So on the CABG versus PCI debate, the best paper we have currently in the best study is this pooled patient-level meta-analysis that was published a couple of years ago in The Lancet, pooling data from the 4 large randomized trials, including one run here in Korea, of drug-eluting stents versus PCI, about 4,400 patients. You can see they had intermediate syntax scores. Most of the patients had distal bifurcation disease. Intracoronary imaging was used in about 2/3 of the patient, and the primary endpoint of this analysis was 5-year mortality. You can see the individual pooled data survival curves here, or mortality curves, and there really was no significant difference whatsoever. The difference after 5 years was 0.9%, not at all statistically significant, and the probability of a survival difference of greater than 0.2% per year is less than half. 2 of the trials actually continued to cover patients, follow patients out to 10 years, including the pre-combat trial and the syntax trial. And again, here you can see no overall difference for these randomized patients between bypass surgery and PCI. And finally, they were able to do a very nice analysis looking at the interaction between disease complexity as assessed by the syntax score and the mortality hazard ratio. And you can see as long as the syntax score is less than about 35 or so, there really was no measurable difference here. But as you got above about 35, or we can say 33 for the points of the guidelines, the survival benefit clearly started to favor bypass surgery, and I think there's not a lot of debate about that today. So what do I think? What's missing from the guidelines based on the data we have? Well, actually here, I think they got it pretty right. I think both the ESC and the AHA guidelines both got the indications for revascularization and the selection of an initial revascularization reasonably correct within the level of the evidence that we have. What about mechanical circulatory support? This is a big debate really in the United States. I don't know if it's quite so relevant outside of the United States, but this is the patterns of use of mechanical circulatory support beyond the balloon pump in the United States over the last 8 years or so. And you can see there has been, a substantial increase in the use of mechanical circulatory support across all PCI procedures. And one of the things that's driving that most is the treatment of patients with unprotected left main disease. And so this really is an issue and a question for us in the United States. And I think there are really, two sides to it. What is the evidence that we have in 2023 for mechanical circulatory support in left main PCI? We have the BESIS-1 trial, which was a balloon pump trial of patients with left ventricular dysfunction and major myocardial jeopardy. About 30% of these patients had unprotected left main disease, and there was no benefit of support with a balloon pump in that trial. The PROTECT-2 trial is a trial of Impella. It enrolled patients with unprotected left main, also patients with substantial heart failure. About a quarter of the patients had unprotected left main. This was an Impella trial with the earlier generation of the Impella device and showed no difference in the primary endpoint at 30 days, but there was a trend towards benefit at 90 days, although it was not statistically significant. And I think very importantly, just to mention, is that in the major trials of PCI versus bypass surgery that I already highlighted, very few, about 5% of those patients actually got any form of support during the procedure. So what else do I think the guidelines should have said about mechanical support in left main PCI? I think they should have said that among patients with unprotected left main PCI with normal LV function, planned mechanical circulatory support is rarely needed, but it should be considered when the left main anatomy is very complex, such as severe calcification requiring atheroablation, and cardiac reserve is limited, like an ejection fraction less than 30% or a markedly elevated wedge pressure, or if the left main anatomy is very complex and the right coronary is occluded and supplied by left to right collaterals. That's at least my personal view. Finally, just a word about one stent versus two stent strategies. Again, we have a couple of randomized trials that have provided some information here. So there's the DK Crush 5 trial run out of China, 482 patients with true distal bifurcation lesions, randomized to either provisional, a single stent strategy, or a DK Crush strategy. The primary endpoint was target lesion failure at 1 year and was lesion centered. And very importantly, this trial had angiographic follow-up, although it was supposed to have been done after the primary clinical endpoint had been assessed. The other trial is from the other side of the right down the street from here, actually from Monmouth's neck of the woods, the EBC Main trial, 460 patients with true distal left main bifurcations, provisional stenting versus a two-stent strategy. Here, the two-stent strategy was up to the investigator. They could use whatever they thought was most appropriate. The primary endpoint was a patient-centered endpoint of death, MI, and target lesion revascularization, and there was no angiographic follow-up. And interestingly, those two trials, with those differences, came to very different conclusions. So the DK Crush trial, 5 trial, showed a significantly worse outcomes with the provisional strategy. Whereas the EBC Main trial showed no significant difference for the composite endpoint or for any of the components, and actually the two-stent strategy actually had a little bit worse outcomes, but not statistically different. And I think it's important when we look at DK Crush 5 to see where those curves separated. So there was a very significant early separation, which is probably related to peri-procedural MIs. And then here's this late separation, which looks like it's something that's been associated with the angiographic follow-up. And so I'm not sure that that really tells us about the clinical differences. I think this is being driven a lot by some of the protocol-related factors. So what else should the guidelines have said? I think they should have said that an optimal strategy is uncertain with respect to the number of stents. The choice of the strategy should be based on a combination of angiographic features as well as the operator expertise. And they should have said that intracoronary imaging is mandatory both pre and post PCI. So in summary, a revascularization strategy is strongly recommended for left main stenosis greater than or equal to 70%. Bypass surgery is certainly preferred for patients with a high syntax score or left main plus 3 vessel disease, whereas PCI is reasonable for less complex disease. And obviously, a heart team should be involved in shared decision-making for these cases where both are feasible. I believe, and I think there's emerging consensus, that imaging guidance is appropriate for all left main PCI. Mechanical circulatory support is rarely needed unless the patient also has limited cardiac reserve. And finally, in 2023, the optimal stent strategy remains somewhat uncertain. Thank you very much.
So thank you, David. We're going to have the panel discussion at the end. If I can ask Sripal Bangalore next to discuss multivessel revascularization, consensus and gaps in 2023. Over to you, Sripal.
Thank you very much, and thanks for inviting me. It's great to be here. And since the session is about, it says after the ischemia trial, so I'm going to kind of focus on the ischemia trial. These are some of my disclosures as it relates to this particular trial. Let's take a quick look at ischemia trial and see what we can glean in terms of management of patients with multivessel coronary artery disease. In the ischemia trial, we randomized over 5,000 patients, randomized to invasive versus conservative strategy, making this the largest treatment strategy trial of stable coronary disease. We enrolled a high-risk subset of patients. More than half of the patients had severe ischemia. 76% of them had multivessel disease, and nearly half of these patients had proximal LAD disease. In patients who were randomized to invasive strategy, 80% were revascularized. It's important to note that nearly 26% of patients who were revascularized had the revascularization method being CABG. So this is not a trivial number. In patients who were randomized to conservative strategy, 28% underwent cath and 23% were revascularized at 4 years, but most of this was for a primary endpoint event. In terms of medical therapy, we had high optimal medical therapy attainment, with 95% of them being on statins, 2/3 being on a high-intensity statin. The LDL achieved was 64 milligrams per deciliter and systolic blood pressure of around 129. It's also important to recognize who are not enrolled in ischemia. So if you had ACS within 2 months, EF less than 35% was also an exclusion because this was tested in the STITCH trial. If you had NYHA class 3 or 4 heart failure, or if the patients were really symptomatic, these were patients not enrolled in the trial. So let's go back to the drawing board and ask, what are the reasons why we should consider revascularization, particularly in this case, multivessel coronary disease, and let's assume that these are stable coronary disease and not ACS patients. One of the reasons we generally say why we should revascularize is potentially to improve survival. So does revascularization improve survival in stable coronary disease patients? If you look at the contemporary trials of revascularization versus medical therapy, one commonality of all of these trials, whether it's COURAGE, BARRY-2D, or even the FAME-2 trial, has been there is no difference in overall survival. And if you look at the ischemia trial, again, the same pattern, no difference between invasive and conservative strategy in the ischemia trial and also in the ischemia CKD trial, which had the honor to lead. And what you can see from the ischemia trial is the curves are overlapped, and there is no separation of curves, either early or even late. This is the results which we published last year, looking at ischemia extend, which is a longer-term follow-up of the ischemia trial. So this is the curves for all-cause death in the conservative strategy. This is for invasive strategy. 2 curves superimposed. This is at 7 years of follow-up. No significant difference between invasive and conservative strategy for all-cause death. If you look at cardiovascular death, the relationship is slightly different. So there is a 22% decrease in the risk of cardiovascular death with invasive when compared to conservative strategy. This translates to a reduction in cardiovascular death of around 0.3% per year. Why did we not see an overall difference in death? That was because the invasive strategy was associated with significant increase in non-cardiovascular death, a 44% increase in non-cardiovascular death, thus negating the benefit we saw from reduction in cardiovascular death. So going back to the drawing board, in the overall cohort of patients with stable coronary artery disease, there is similar survival with revascularization compared to medical therapy, but there is a small reduction to the order of around 0.3% per year in cardiovascular death. Let's now focus on the high-risk subgroup of patients. What about patients with left main disease? David elegantly went over all of the data for left main disease, but in terms of revascularization versus medical therapy, the data for left main is based on these 150 patients who were randomized in the CABBAGE versus no CABBAGE trials done back in the 80s. So we do have data for survival benefit of CABBAGE, but again, the caveat being that these are older trials and based on 150 patients. What about patients with LV systolic dysfunction? This was tested in the STITCHES trial. At 10 years of follow-up, 16% reduction in mortality with CABBAGE when compared to medical therapy alone, number needed to treat of 14. In the ischemia trial, we excluded patients with EF less than 35%, but we did have patients with EF 35 to 50. And in that group of patients, we found that the invasive strategy significantly reduced the primary endpoint. There was also reduction in CV death or MI with invasive strategy when compared to conservative strategy. So in other words, in the ischemia trial, the patients with EF 35 to 50 somewhat behaved very similar to those of STITCHES in that there was a benefit of revascularization. So for LV dysfunction, clearly CABBAGE versus medical therapy, mortality benefit, and in the ischemia trial, invasive versus conservative for those with intermediate EF. But for CABBAGE versus PCI, we need randomized trials, and there are many currently in the works. What about triple vessel disease group of patients? Again, if you look at the 1980s CABBAGE versus no CABBAGE, significant benefit, mortality benefit of triple vessel disease group of patients with CABBAGE. But if you look at same CABBAGE 2009 Barry 2D trial, two curves superimposed, no significant benefit, mortality benefit of CABBAGE in diabetic multivessel disease group of patients. We looked at some of this data in the ischemia trial, categorizing patients into Duke categories of, and specifically if you focus on Duke 6, which is triple vessel disease or patients with two vessel and proximal LAD, interestingly, what we found was there was significant benefit of invasive strategy at reducing CV death or MI in this subgroup of patients. There was no significant difference in all-cause mortality, and this benefit seems to be driven by a reduction in myocardial infarction. And what about proximal LAD? Proximal LAD in the ischemia trial was not an effect mediator, so there was no difference in the effect of invasive versus conservative, whether the patient had proximal LAD stenosis or not. And what about extensive ischemia? So here is the breakdown based on ischemia severity. Severe ischemia, moderate ischemia, mild or no ischemia, and the endpoint is all-cause mortality. Again, no significant difference whether patients had severe ischemia or not when compared to that of conservative strategy. What about other reasons to consider revascularization stable coronary artery disease? Can we prevent other cardiovascular endpoints? In the ischemia trial, invasive strategies significantly increased procedural MI, but there was a significant 33% reduction in spontaneous MI when compared to that of conservative strategy. We also showed that invasive strategy reduces unstable angina and lowers cardiovascular stays. And more importantly, what about quality of life? In the ischemia trial, invasive strategies significantly improved quality of life, including angina frequency, angina-related quality of life, and this effect was long-lasting up to 4 years of follow-up. But this was not seen in patients who are not symptomatic. Just to summarize, the potential reasons for revascularization in stable coronary disease to improve survival, no improvement in survival compared to medical therapy except in those with left main disease and LV systolic dysfunction. There is a reduction in cardiovascular death, but revascularization reduces spontaneous MI and stable angina and lowers cardiovascular stay, and more importantly, there is faster and more durable relief of angina in symptomatic patients. Finally, to look at the 2021 ACCHA revascularization guidelines, I had the privilege to be part of this guidelines. For left main disease, we gave class 1 for improvement of survival for CABBAGE. For triple vessel disease, for overall improvement in survival, both for CABBAGE and PCI, it's a 2B recommendation. For ProxLAD, again, a 2B recommendations to improve survival. But for 1 or 2 vessel and no ProxLAD, it's a class 3, no benefit for approval of survival. So, but once we move beyond survival, so we do have a new recommendation. So in patients with multivessel coronary disease, revascularization is reasonable to lower the risk of cardiovascular events such as spontaneous MI, unplanned urgent revascularization, and cardiac death. And this is a class 2A indication. Thank you for your attention.
Thank you for that. Next presentations, we're going to move on. Mamas is Main PCI, who and how. Please.
So thank you for this great opportunity. Over the next 8 minutes or so, my focus will be who should do left main and how. We've had this presentation already by David, showing us the guidelines around whether we should actually be doing left main, and very much the European guidelines focus a decision around making left main around complexity of the syntax score, as you can see. When undertaking left main, we should really adopt the radial first approach. It's feasible. There's a lot of data around it. This is data from the UK BSIS registry looking at access site-related outcomes for left main PCI. You can see in the UK around 60% of all left main PCI was undertaken radially in 2014. The rate is about 90% now. The radial access site is associated with a reduction in access site-related bleeding complications, and in hospital major bleeding and death. Now you may say, well, okay, that's registry data. Do we have any randomized data? And we do. This is Adela Minion's complex PCI randomized trial using 7 French guides. And again, you can see that adopting the radial approach in 7 French interventions associated with a marked reduction in BARC 2, 3, or 5 major bleeding complications. Does it matter where you do left main PCI? It probably doesn't. This is data again from the BSIS registry, looking at left main PCI outcomes according to whether the site is surgical or non-surgical. And you can see that there's no meaningful difference in outcomes for in-hospital events. And around 40% of all PCI to the left main is undertaken in non-surgical centres in the UK. The vast majority of PCI centres in the UK are non-surgical centres as well, about 60% of them. Intravascular imaging, if you're doing left main, I believe that it should be mandatory to do intravascular imaging. It helps you understand the plaque burden, distribution, bifurcation angle, helps you characterize calcium, whether it's circumferential at depth, and really helps guide optimization and stent result. Is it important? This is our data looking at left main with intravascular imaging, showing that at 1 year there's a prognostic impact and a 30% reduction in mortality. This is the 10-year data from Dr. Park on the panel, again, showing reductions in both all-cause death and composite outcomes associated with imaging. And from randomized controlled trials, this is, again, a great South Korean piece of work, the Renovate Complex PCI trial, showing an improvement in outcomes, particularly cardiac death and the primary endpoint, but even in the left main subgroup, again, consistency of effect. So we have observational and randomized trial data suggesting that we should be using intravascular imaging in this group of patients. And again, it's useful. Why? It helps you guide stent expansion, and we know that stent expansion is associated with improved outcomes in left main. I think when undertaking left main, you have to be familiar with both the assessment of calcium and how to use tools to treat calcium, including rotablation, lithotripsy, and so forth. And if you don't have familiarity in using these tools, you probably shouldn't be doing left main PCI. Why is it important? Well, we know that calcification in coronary arteries, whether you're using first, second, or third generation drug-eluting stents, portends to worse outcomes, as we can see here. You have to think about what platform you're using. I mean, not all platforms are the same. They have different expansion profiles. And so you can see here that a 3.5 stent platform will expand to very different diameters. And so particularly if you're stenting from LAD into left main, I think it's important, using information from intravascular imaging, to choose the optimal platform that will actually expand to your left main diameter in these cases. The 1 versus 2 stent approach, I think for non-true bifurcations, I would always advocate the single stent provisional approach, size the distal vessel. Clearly you need to pot, and if the side branch is compromised, then final kissing balloon, and always finish off with a pot. In terms of true bifurcation lesions, I guess the approach, to my mind, very much depends on the anatomy and the severity of the side branch disease. We know from the definition true trial that in complex bifurcations, a two-stent approach is better than provisional. In terms of randomized trials in left main, we have DK Crush 5 showing superiority of the two-stent approach compared to the provisional approach. Whilst the P4 interaction is negative, certainly in terms of magnitude of benefit, there seems to be much greater effect in the complex lesions than in the simple lesions. In terms of EBC main, these were slightly more simple cases. The average side branch length was much shorter than the DK Crush trial, as you can see here. And there was no significant difference between the stepwise provisional and the two-stent approach. This year at EuroPCR, we're going to have the 3-year outcome data. I suspect they're probably going to be very similar, but let's wait and see. And finally, should everybody be doing left main PCI? Probably not. This is data from the UK BSIS registry. There's also similar data from China showing very much a volume outcome relationship for left main PCI in these patients. So if you're a low volume operator, you should not be doing left main PCI. In my view, left main PCI should perhaps be undertaken by only 1 or 2 operators in the unit that have higher volumes rather than, people trying to do it with very low volumes. It's not appropriate, and there is certainly differences in hospital MACE mortality and 12-month mortality related to volume of left main PCI. So I think in summary, it's a reasonable treatment strategy for those with low and intermediate syntax score. You need to go radially. Intracoronary imaging is mandatory for all cases. I think for simple cases, provisional approach. For more complex cases, two-stent approach. Volume matters. If you're a low volume operator for left main, don't do it. Ask one of your colleagues to do the case or do it with you. And in terms of final, it probably doesn't really make much difference where you do the case. Certainly in terms of surgical versus non-surgical centres, from the UK registry data, there doesn't seem to be any difference in outcomes. And in fact, in non-surgical centres, individuals are much more likely to use intravascular imaging and the radial approach, so better practices in non-surgical centres. So with that, I hand back to the chairman. Thank you.
Thank you, Rico. So we're going to move next. DM, diabetes, and the triple vessel disease, old evidence, and the new trials. Duk-Woo Park from Aspen Medical Center.
Okay, thank you, SJ. So today my topic is about the diabetic and multivessel disease and old evidence and the new next trial. This is my disclosure. And everybody knows well diabetic is a common comorbidity in coronary artery disease and usually involved with a more aggressive form of atherosclerosis, and also major determinant of adverse outcome after PCI, either bypass surgery. Also, the absolutely diabetic patient, high risk ischemic cardiovascular event and mortality compared without diabetic patient. And what are the available old evidence in PCI versus bypass surgery in diabetic and multivessel disease? And this is syntax diabetic sub-study, and only 452 patients diabetic, and the primary endpoint, hard endpoint plus repeat revascularization much higher in PCI, and hard endpoint no difference, and repeat revascularization is the main confounder of a primary endpoint difference. And the last year in TCT meeting, we presented the best trial 10-year follow-up, and overall, and no difference, the SMI and the TVR primary endpoint, the bypass surgery and PCI, and the mortality and the composite endpoint was no difference at all. But looking at the diabetic subgroup, there was a significant interaction, and a diabetic patient much hazard with the PCI rather than bypass surgery, and looking at key components, and no difference deaths or stroke MI or all-cause mortality, and the major difference was repeat revascularization. So, and looking at the landmark or RCT specifically targeting diabetic patient with multivessel disease, and Freedom and Verity trial. Freedom trial is one of landmark trial, current guideline update, the contemporary guideline update, Freedom trial result, and this is death, MI, stroke, and the primary endpoint was a favor bypass surgery rather than PCI. All-cause mortality was lower in the bypass surgery. And the Freedom trial 10-year follow-up was main finding was consistent up to nearly 10-year follow-up. And the Verity trial, they do stratum and the revascularization versus OMT, and the overall group no difference, and the PCI stratum survival no difference. Bypass surgery was no difference. And in the hard endpoint, death, MI, stroke, and the overall outcome no difference. PCI stratum less severe coronary artery disease no difference. OMT versus revascularization. Bypass surgery stratum, as there is some MI difference, and the revascularization was better. So, and that was absolutely adapted in the current contemporary guideline, looking at the European guideline, diabetics, triple vessel disease, bypass class 1, PCI 2B or 3. And the updated US guideline, bypass surgery class 1, and the PCI could be option in poor candidate for bypass surgery, and this is a PCI regarded 2B or 3. So, and what are limitation prior RCT, and that was not focused on diabetic and underpower sub-study, and don't use the current contemporary drug-eluting stent Freedom and Syntax trial, also not frequently used intravascular imaging concept and physiology concept, and Syntax and Freedom trial also do not use the updated GDMT like SGLT2 inhibitor or GLP-1 receptor agonist that is absolutely current practice, and Freedom and Verity trial. And you know, in contemporary PCI era, absolutely precision medicine using assessment is FFR and Yves that would be nearly mandatory for complex PCI. Also remarkable advance in diabetic medication, and GDMT was much emphasized. Also diabetic patient, the first line recommendation GLP-1 receptor agonist or SGLT2 inhibitor. This is not adapted in prior trial. So, and the recent FAME3 trial was published in New England Journal of Medicine, and diabetic patient and bypass surgery was better. And the FAME3 trial, one of the limitations, the intravascular imaging only used in 10%. There was not fully evaluated using the Yves in the complex patient. What would be next new trial in patient diabetic and multivessel coronary artery disease? I'm happy to introduce our upcoming new trial, DEFINE-DM trial, and the trial hypothesis was advanced state-of-art PCI using intracoronary imaging, Yves or OCT, intracoronary physiology, FFR or IFR, contemporary drug-eluting stent, and with GDMT, advanced cardiovascular anti-diabetic medication, SGLT2 inhibitor or GLP-1 receptor agonist in patients with type 2 diabetic and multivessel disease would result in similar outcome to bypass surgery in contemporary trial. This is our DEFINE-DM trial, and we are targeting 1,200 patient diabetic multivessel CAD with the involvement of LAD, equally eligible for PCI or bypass surgery, decision by heart team discussion, and the randomization 600 imaging and physiology guided state-of-art PCI and versus contemporary standard bypass surgery, primary endpoint, death, all-cause mortality, MI or stroke. At 2 years, also we planned a 5-year and 10-year extended follow-up, and inclusion criteria was multivessel disease involving LAD involvement, and exclusion lab main disease, STEMI, and cardiogenic shock. And the endpoint, as mentioned before, death, MI, stroke at 2 years. Also, we measured the several secondary endpoint and the functional status, NGNI CREST, and the health-related quality of medicine. So sample size was a non-inferiority design. We are select 1.54 non-inferiority margin, and we are planned to enrolled more than 1,200 patients, 50 sites over 4 years. So, and the key message, all the evidence suggests bypass surgery was always better than PCI in patient diabetic and multivessel disease. This was unanimously adapted in contemporary revascularization guideline. Bypass surgery, always class 1, PCI class 2 or 3. However, there are several limitations for interpreting prior random trial, also some trial already old-fashioned and still unmet need exists in contemporary advanced PCI era. We need the next new trial comparing imaging physiology-guided state-of-art PCI, combine the advanced GDMT, and comparing to bypass surgery in patient diabetic and multivessel disease. This will be validated in the future trial, DEFINE-DM trial. Thank you for your attention.
So if I could introduce the next speaker, Dr. S.J. Park, who will focus around not touching the small side branch. So over to you.
Thank you. All right, I want to talking about the small side branch interventions. If you look at the YPCIs, patient with a stable ischemic heart disease, just two things: to improve symptom, to improve survival. To improve symptom consent should be ischemic symptoms. To improve survival. So Dr. Bangalore has already reviewed, ischemia studies, most impactful study since Courage study. For the patient with moderate to severe ischemia, separated initially invasive and initially conservative treatment. They included more than 75% of multivessel disease. Primary outcome at 3 years, anyway, composite endpoint, no difference. All deaths, no difference. Last year's all deaths at more longer follow-up data, also no difference at all. So ischemia study simply suggests no survival and ischemic event benefit of invasive strategy as compared with the conservative strategy for the patient with moderate or severe ischemia. Optimal medical therapy is good enough for majority of patients of stable coronary artery disease. So summary from the ischemia studies, any improved survival for a main disease, low ejection fraction, multivessel disease, low ejection fraction, CABS class 1, clear multivessel disease. In normal ejection fraction, still bypass surgery, PCI is class 2B indication. You have to remember that. Diabetic cerebral disease, low ejection fraction, CABG class 1A. So main issues in the bifurcation PCI is small ischemic burden of side branches, real size of side branch. If you look at the percent fractional myocardial mass study, look at this, and LAD circumflex is the main bifurcation, and prox LAD diagonal, mid LAD diagonal, 2 circumflex obtuse marginal. All side branch actually has a less than 10%, a fractional myocardial mass. If you look at this, more than 10% of fractional myocardial mass in non-left main side branch, only 20%, and main bifurcation more than 90%. Anyway, circumflex is great, bigger than more than 10% fractional myocardial mass. And so non-main bifurcation PCI, conceptually, 80% of side branch is a non-main bifurcation. It's a small ischemic burden. That's the main clinical outcome of non-main bifurcation PCI, clearly related with the main branch stenting status. So I would say, simplify, bifurcation PCI, larger size branches, we define more than 2.5 millimeters. So you have to explain it a little more. However, small size branches, just leave it alone, not treat. And so larger size branches for the true bifurcation disease, I would say upfront to stent technique would be good, it's better. In any bifurcation, so main or non-main, However, small side branches, more than 80% real world, less than 10% of fractional myocardial mass, survival benefit, absolutely no. Ischemic symptoms with optimal medical treatment, as I don't believe that one. And so just, we can say that, don't touch. All right, look at, if the true bifurcations 111, 210 is good. There's not too much data. However, this is our data. 1 stent or 2 stent technique, both good. This is the definition to trial. 2 stent would be better than provisional 1 stent. The reference vessel diameter is more than 2.5 millimeter size. Right. So, no doubt about the main bifurcation. Look at this. Distal. Bifurcation disease, we did predilation and circumflex stent, balloon crush for main branches, and finally, RAD main stent has a final kissing balloon inflation, sequential high pressure after the sequential high pressure inflation. And so we can get very good angiographic result here. This is our view, another view, clear. For the main bifurcations, finally, we got a very good effective stent areas after high pressure inflation. Look at that. This is another case. Upfront to 2 stenting for LAD diagonal branches. As a diagonal branches, a relatively big one. So we do just upfront to 2 stent crush for the LAD diagonal branches. Another case is circumflex. Obtuse marginal branch is frequency-wise is more than 40-45%, had a more than 10% of fractional myocardial mass, relatively big, Jafary area. And so in some cases we want to do, upfront to 2 stent. So in case of upfront to 2 stent, largest side branch more than 2.5 millimeter scale is worst of treatment. We can avoid the risk of side branch closure. Clinical outcomes of a 2 stent are good, and so we don't hesitate to upfront to 2 stent. Main, we have some effective stent area cutoff value here, 5, 6, 7, 8 millimeter scales to reduce the restenosis rate here. In any epicardial artery, the only predictor for good clinical outcome, actually effective stent area is more than 5 millimeter scale, and stent length less than 50 millimeters. If you do contemporary PCI using their Yves guided, something like it is perfect. The restenosis rate is less than 2%. So small side branches, don't touch it, leave it alone. Look at this, ready crossover, not small. However, after the main stent crossover, the compromise, team is 3 diagonal branches. However, the thing just leave it alone. And sorry for that. I would like to show another cases here. Jailing diffuse LAD disease here, calcified region. After the long stent, absolutely disappeared diagonal branches. Even particular this case, jailing diagonal branches, just don't touch. Big diagonal branches, asymptomatic jailing side branches, if you look at the FFR concern, even in the high degree of stenosis, more than 72% of cases is negative FFR. It's asymptomatic jailing side branches. Even after kissing balloon inflation, visually tight stenosis, we want to do the kissing balloon inflation, absolutely we didn't find any difference after the kissing balloon inflation. Aggressive management, high pressure inflation, between kissing may have a little bit higher frequency of restenosis rate, a little bit higher target vessel failure, aggressive treatment concern. And so simply, I would like to say in my rule for bifurcation, symptomatic, large size branches, upfront to 2 stent would be good. Have a small side branches, less than 2.5, no symptoms, jailed or not after main stenting crossover, medical therapy enough. Just in case of a symptomatic compromised side branches, just balloon with or without DEB would be enough. And so no symptoms, small side branches, no survival benefit. Why would you do that for the treatment? Just don't touch for the small branch. So we don't need any more bifurcation club, those and what? All right, thank you for that.
So thank you very much for a very entertaining talk. The last speaker for this session is remote, Dr. Ajay Kirtan, that will talk about whether CTO PCI should be very selective. So are you there, Ajay?
Congratulations on a wonderful meeting. So sorry I can't be there in person. I'm going to approach this talk from the perspective of a thoughtful clinician who should be cautious and selective in our approach to CTO PCI. Here are my conflicts. Here's the premise for the talk. Number one, we ought to be selective in our choice for CTO PCI because the data in favor of it are entirely for symptom relief for those with the most severe symptoms. Number two, CTOs are inherently stable, they're chronic, and because these vessels are already occluded, there's no rush to treat them and medical therapy and other options could be explored prior to undertaking a CTO PCI. We all know that CTO PCI is not straightforward, even for the best of operators, and I would actually posit that most operators are not adequately trained to treat them effectively or reproducibly. Therefore, another reason to be selective up front. And finally, we do know that the risks of CTO PCI are significantly higher and need higher end skills to be able to treat those complications if they occur. And that's another rationale for why we ought to be selective. So starting off first with the data, I think it's pretty clear. Canvas is on the panel here. He presented data from Revasc. There's other data from trials like Explore, and then ultimately trials like Decision CTO that do not support CTO PCI for a prognostic benefit. Now, I'm not saying that there is no prognostic benefit to opening up a CTO. I'm simply saying that the current data as it lies does not support that approach, which is an argument to be selective about the types of cases in whom we might posit an improvement in ejection fraction or an improvement in clinical outcomes. Remember, all these trials have limitations, though. Trials like Decision CTO was stopped early. Half of patients got non-CTO PCI, introducing noise into the randomized comparison. There was immediate crossover from some patients who were initially assigned to non-CTO PCI. And at baseline, the symptom status was pretty good with patients having minimal symptoms at baseline. Ideally, we need to take patients with more severe symptoms, and that's yet another rationale for why we ought to be more selective, because just because we see a CTO doesn't mean that it necessarily needs to be open, because it might not be causing any symptoms or problems for the patient. Now, that having been said, even among patients who are randomized in Decision, if we look at clinically meaningful increases in terms of quality of life or decreases in angina, that was seen among patients with the most severe symptoms at baseline. This is unpublished data from the trial, but showing that despite the noise in the sample, you could get a signal. You could isolate a signal of benefit if we restrict our analyses to the most severely symptomatic patients. These data are clearly supported by the EuroCTO study. Gerald Werner led the study and showed pretty clearly that you could reduce anginal burden by improving flow through opening a CTO. This was an important study and I think is really the basis, randomly speaking, or randomized trial-wise, for opening CTO PCI in those that have the most severe symptoms. There are other streams of data, non-randomized data. This is from OpenCTO showing that for patients who have refractory angina that's refractory to multiple medications, these are the ones who get the most benefit from successfully opening up a CTO PCI with PCI. So I think my statement on all of this is that take the most severe patients and revascularize those ones. The other ones, you can try medical therapy and otherwise first. So to summarize, the data is entirely for symptoms. It's in those with the most severe symptoms, and at present, there does not appear to be a prognostic benefit. The other part of this is that CTOs are inherently stable. And so if someone has mild symptoms, it's not unreasonable to start with medical therapy and try other options first. That having been said, if we actually have patients that remain symptomatic or don't wish to be on medical therapy, we'll get letters like this from our patients where they thank us for our help. It's a great feeling to be angina-free. And remember, in these patients, you can then take them off their anti-anginal therapy and still maintain symptom benefit. That's an important thing for patients, and I think it's an important rationale for opening up CTOs in our most symptomatic patients. The other part, though, is we don't have to revascularize everybody. This is a letter I got from a patient who came for consultation, and the patient was asymptomatic, able to do all the activities that he wanted to do. He was very worried about his blocked artery, and after speaking, we decided to treat this medically, and he sent me a note saying he was very thankful that I explained it for him. He was less worried about it than he had been before, and he's done very well. And I would posit that a large proportion of patients that we see actually are pretty asymptomatic or can be managed medically, and there's no reason to rush to CTO PCI. Of course, for those that are symptomatic, we don't want to deprive them of that benefit, but this is also a true fact that we see. The third part of this is that CTO PCI is not straightforward. I think we all know this. We all go to meetings to see the latest techniques and ways that we can do these procedures more safely and reproducibly. But the bottom line is that even in expert hands, these are not the most straightforward cases. They can still be challenging. And I would posit that most operators are actually not adequately trained to treat these CTOs effectively or safely. This is just data from New York State here in the United States showing that volume is clearly associated with outcomes. If you do less CTO PCI, you're less successful at doing it. And that's another argument to be selective because not every patient gets to see a CTO specific operator. So if you're taking care of a patient and you don't have those skills, of course you should refer the indicated patient to someone else, but this is an argument to be a little bit selective in our approach as opposed to treating everybody. This is further exacerbated by locales like the United States, but there are many countries around the world that have similar numbers where a lot of operators are doing low volume. In the United States, nearly half of operators perform less than 1 PCI a week. These are not operators who should be doing CTO PCI that inherently carry higher risk and require a higher skill set needed to treat them. And this risk issue is important to talk about openly and objectively. I think at many conferences, we see amazing cases being done and everybody wants to think that they could emulate those results, but the reality is they can't, and even expert operators have higher rates of complications with CTO PCI. That's just the nature of the type of procedure as well. And you need high-end skills to be able to get out of these procedures. This was from OpenCTO. This was a large registry of expert operators here in the United States with really, really challenging cases and expert technical skills. And the overall rate of mortality was just about 1%. So for a stable patient who's walking around and comes into the hospital and you're saying to them that they have a 99% chance of survival, that's great, but a 1% chance of not living past the hospital stay and potentially even higher at 30 days, that's a tall task for a patient to take, and you have to select the right patients. You have to actually know how to treat these complications. And if we look at rates of clinical perforation that range from the 5 to 7% range, we need to know how to treat those effectively, and patients need to be told of those risks. That's, I think, one of the reasons why the guidelines, to much uproar in the CTO community, came out with a class 2B recommendation for CTOs. Personally, I don't think 2B is the right recommendation. I would have looked at some of the data like EuroCTO and made it 2A. But I think the rationale for this stems from the fact that there are limited data and there are inherently higher risks, and there are a lot of operators who are not trained to successfully treat these cases. And so for the average operator, maybe it should be a 2B indication, but for expert operators, obviously it should be a higher level indication than this. Other aspects of the guidelines that are important to stress are that they recommend spending sufficient time to talk to the patient, engaged in shared decision-making, and allowing for a second opinion. So if you can't do it yourself, get the patient an opinion if they're indicated with somebody who can. Discuss the specific risks and benefits, discuss your actual personal outcomes and your center's outcomes as well. And all of these are important facets to the informed consent process as a whole. We also need to take variability in practice into account. This famous slide from Syntax shows that at different sites, patients do differently with different therapies. And so if you're a really, really high-end surgical site and you don't do a lot of CTO PCI at that site, patients with large or high Syntax scores or high degree complexity of disease probably should go for surgery. But if you're a site that has really great CTO operators, then those are patients that hopefully people are referring to you so that they can actually be taken care of adequately without just being relegated to medical therapy alone. So I think I've hopefully shown you a compelling argument for why we ought to be selective. I, of course, believe that there are many CTOs that can help patients. I've helped many patients myself in that way. Our program is proud of what we do in that regard. But I do think that we're very selective in our approach. We make sure that the data and the indications line up for the patient. We make sure that those patients are talked about with this and they've actually tried medical therapy first. We be sure to scrub with multiple operators when needed, or have expert operators scrub with less expert operators together so that the outcomes are consistent across whoever it is in our cath lab. And we make sure we tell patients of the risks because they are substantial. So with that, I think we can have a great discussion, and thanks so much for your attention.
All right. Thank you. So we have very excellent distinguished reviews, updated main, MultiVessel, and bifurcation, and CTO interventions. Actually, after ischemia study, we've changed, the conceptual. And so, all right, we will discuss from the panels. Any question and discussion point? Dr. Goel, please.
Okay, so I'd like to discuss this point with Dr. Bangalore. So that for this, the presentation was excellent, and it is very interesting to see the results and influence of outcome-based anatomical discrimination versus ischemic burden discrimination. And most data from the ischemia trial show that the anatomical stenosis-based discrimination, such as proximality plus two vessel or triple vessel disease, is better than the severity of ischemia. So that my question is it time for us to change our focus to anatomy, or is that just a matter of MPI?
Yeah, so no, I think that's a great question. So I can tell you both in the ischemia and also ischemia CKD, anatomy is a better prognosticator than ischemia. My personal bias on this is defining anatomy is more useful than looking for ischemia. And of course, ischemia has its own flaws in how which modality, etc. But I think defining anatomy is key. I agree with you.
Just a comment on that as well is that, remember, these were core lab analyses, so a greater than 70% stenosis by QC is a really tight lesion. So those lesions are more likely to end up with spontaneous MI and target lesion failures.
So while saying about that, I think that one very important discrimination is that the MPI ischemia versus tree ischemia, because we know there are several limitations of MPI in defining ischemia, even though it is a classical paradigm for evaluating the ischemia, but we have to discriminate the tree ischemia versus MPI-defined ischemia.
Yeah, absolutely.
One question to Dr. Park, since you are an expert in left main and bifurcation, if you do left main to LAD and on imaging, you see non-flow limiting 2 or 3 struts across the circumflex origin, do you open it or do you leave it alone?
All right, depending on digital status of a circumflex ostium and how long region length is, etc. Truly disease, we don't hesitate to stand upfront to stand for them. And in case of a normal circumflex ostial case, it's just a main crossover, depending on any angles, anatomic situation, sometimes angiographically compromised, circumflex ostium. In normal-looking circumflex, based on our data, just only 7% of those cases are positive FFR. Even there are some, 80%, 90%, angiographic stenosis. And so we don't believe too much about, routine kissing, balloon inflation, something like that. And so there is a little bit change the contemporary PCI, so different.
One of the really interesting slides that David showed was around left main practice in the US and the 10% use of support devices, LV support devices. David, why do you think it's so high? I don't know what the practice in Korea, but in Europe, certainly, it's probably about 1%.
Can you hear me? Yeah. The U.S. is unique with respect to use of mechanical circulatory support, largely because there's reimbursement for it. So around the rest of the world, this is a very expensive device, and you think very, very hard about it. In the U.S., it's favorably reimbursed for most hospitals, and so there isn't an economic pressure not to use it. And we have a generation, I think, of people who are coming through our training programs who are very comfortable with Impella, with closure devices and other techniques for optimizing that, using the single access technique, all of these different things. So I think it's a combination of factors, but I also think perhaps we're a little bit too reliant on it. I'd ask Dimitri, I think, who has an awful lot of experience, how often are you using circulatory support for unprotected left mains, and what do you think about the practice in the U.S.?
Well, can you hear me?
Yes, yeah, I think so.
The honest answer is we don't know. what we're doing. And we don't really know what the patients that actually benefit or are patients that we actually harm by using mechanical circulatory support. And I think that's why we're doing the Protect 4 trial right now, and I think it's going to answer a lot of this type of questions. I think if someone has a normal EF, I never use mechanical circulatory support, even if it's a rota left main bifurcation with an occluded right, because you had this example. If the EF is normal, I would not use it. An underused tool is the right heart cath. So, and in Europe is not used that often, even if in cases where they use mechanical circulatory support. So I think the answer is evaluate the hemodynamics. Not all EF of 30s have the same hemodynamic problems and so on and so on.
You know what? I think this also tracks back to what we were saying in terms of operator volume. So in the US, low volume operators who aren't doing a lot of left main PCI can use mechanical circulatory support as a crutch and be able to do this PCI effectively and safely. Whereas I think higher volume operators are less reliant upon it and may make that judgment based on other things, such as, you know, whether there's residual disease, what the total syntax is, and what the EF is.
Though this is a little bit of an oxymoron, right? Because you're a low volume operator and you add a complex device in and you're doing a complex lesion. So that might give you a full sense of safety and security, and essentially you mess around for hours in the left main and harming the patient. So I think it's a false sense of safety to put a device if it's not needed, and we've seen a lot of bad things happen.
Yeah, I think it absolutely is an area where we don't have enough good data to use that to inform the decisions. It would be interesting to look at the question that Ziad said of, do lower volume left main operators use it more frequently than higher volume left main operators?
They do, at least this is the experience I have in the hospitals at work, and the results are not good. So it's not something to...
It's not a panacea.
It's not a panacea, it's not something to recommend or advise.
Just a quick question to the panel. In the light of ischemia and now BCIS revived, is it time to become more comfortable with incomplete revasc? In other words, somebody comes with chest pain or even an ACS, fix the LAD and leave the RCA CTO, or even more complex, fix the right and leave the LAD CTO. What does the panel think of that?
Well, I guess, I can make a mention because we did the completeness of revascularization analysis for ischemia, which is currently very close to being in press, I hope, from Jack. I think it's an important point, and you may be right, especially as we move towards understanding completeness of revascularization in a more totalitarian way. I mean, there's 5 different metrics: Jeopardy score, then there's syntax score, then there's anatomic complete revasc and functional complete revasc, and they might not always overlap. We published in JAHA actually a consensus of how to do all of these things together, and we're now reanalyzing data historically from other studies to see which one of these may be the most impactful. Certainly, I think the use of BCIS and Jeopardy score has added value because it looks at the total amount of territory involved.
If I just want to comment on the answer that you gave about what to do with the crossover left main when the circ ostium is okay. And I want to share, I think it's a funny story. I was doing a live case for the CTO plus left main summit back in the day. And I had this exact case. I was normal. I put the stent crossover, and I didn't want to kiss at the end. I didn't want to open up the struts. So there was debate. Everybody was saying his or her own thing. And essentially, I said, okay, let me do an IFR or an FFR, and if it's normal, then I will not balloon. Everybody agreed. I did the hemodynamics, it was normal, and they still made me kiss. So the bottom line, this is another area that we have no idea what we're doing. And everybody, it depends upon the stars or, the moon. So I thought it was interesting.
All right. Still, our concept is changing now, right? And so, based on our small data, it's not big data. However, even in the main bifurcation PCI, if you touch kissing balloon inflation, something like that, no difference in hard endpoint, a little bit higher frequency of T error rate if you do some kissing balloon inflation, more aggressive treatment for that. And so anyway, visually 70% discrete narrowing. So if we want to do FFR, it's okay. However, we know that more than 90% of cases is negative FFR. And so we just leave it alone. We don't touch about it.
We've seen a lot of data, and I guess you guys have presented huge amounts of data for left main PCI using stents. There's an increasing school of thought amongst some operators that perhaps drug-coated balloons in the treatment of left main may give reasonable results. I mean, in South Korea, is anyone using drug-coated balloons as the principal treatment for left main disease?
Mamas, you mean for the circ, to avoid the second stent?
No, the left main.
The left main itself?
Yes.
Oh, that's an
so in the UK, some people are doing that.
Practically, it's not reimbursed and not allowed to use, but in some cases, some operators are using that.
So Simon Eccleshaw in the UK has published a series of left main treatments with drug.
I think for the ostium of the circ, which is the Achilles tendon of left main PCI, I think using a DCB instead of a second stent might be something that we will learn more. I've done it a few times in Europe. They don't let me do it in the US. But I think there may be something there. Avoid putting metal in the circ, especially if there is too much motion. One thing that we don't talk about, we talk about the angle, but we don't talk about how the angle changes. And if it changes a lot, that's a risk factor for stenosis of the ostium of the circ, I think.
Maybe I can mention some new data that we've just submitted, which I think is interesting. So we analyzed all of XL, left main bifurcations, and we looked at 4 different completeness of revascularization scores. The only one that ended up mattering was the Duke Jeopardy score, and the hazard was completely driven by the ostial circumflex. Everything else panned out negative, and it was a 3.2-fold higher risk of death and myocardial infarction if you left an ostial circumflex lesion of greater than 70%. Between 50 and 70%, that hazard completely disappears. So there is something about a very tight lesion, and whether it's carina shift or it's an optical illusion or whatever it is, 70% or greater angiographic stenosis at the end of a left main bifurcation has a very high 3-year event rate.
By QCA.
Okay.
By QCA.
We're going to move to the next session. And before that, anyway, I'm very excited. It's huge changes during the last several years based on the data, practice. David Taggart is over there, since further David, right? In terms of, anyways, the main PCI is more widened and generous, and the guideline concern is 1A. Low and intermediate syntax score would be okay. Something. Do you agree with that? And just one comment for that.
Thank you. If I could make a brief comment about the ISCHEMIA study and the implications of it for clinical practice, for many patients is a disaster. The ISCHEMIA study looked almost exclusively at patients with low severity coronary artery disease and normal ventricular function. The rejection fraction was 60%. On the basis of the results of ISCHEMIA, it's now been used to downgrade the guidelines. CABG has been changed from a class 1A to a class 2B, which now means that out in the wider community, a lot of patients with severe anatomical coronary artery disease will no longer be referred for bypass grafting. So I would personally say that the ISCHEMIA study for those patients with low severity coronary artery disease and normal ventricular function is probably appropriate. But for many patients with severe anatomical disease, I think it's a clinical disaster.
So with that bombshell, we'll move on to the cases.
Thank you.
All right. Thank you. We're going to move. Next case presentations. We would like to show some, practice change in Asa Medical Center and Dr. Bangalore's concept those. And so Dr. Bak will give us the main PCI first.
Okay, thank you. So I'm very happy to introduce our daily left main practice in Asa Medical Center. And yearly we do left main intervention at least 300 up to 400 per year. And this is one of our daily left main the PCI practice. So, and this patient present 63-year-old male and referred to loss of consciousness and effort chest pain. And he had hypertension and hyperlipidemia, and also and currently smoking. And the ECG shows the normal sinus rhythm, and the chest X-ray no cardiomegaly, and the echocardiography shows the ejection fraction 67, no regional wall motion abnormality, and the baseline coronary angiography and the right coronary artery and the mid part, some narrow disease FFR was more than 0.9, and just treated the medical treatment. And the target region, this is epicranial view. You can see the very severe Prox LAD part. Also looks like a trifurcation region, and the ostium was very narrow. And this is the arteriocoral view, and this is the spiral view. You can see is a very complex distal left main disease, and the sock region was extended to the distal sock, and the big, the high diagonal branch is also size is not small. Absolutely, we should treat. And the Prox LAD is a very diffuse disease, and angiographically absolutely complex disease. So, and we are discuss hot team discussion.
All right.
And
Duk-Woo, sorry for that. Would you show the pictures? And so from the panels, this is a little bit more free discussion for cases, right? And so, what do you think? Is a good candidate for surgery, David? As you want to do the PCI or surgery?
No, PCI.
Mama.
I mean, I personally would go for PCI in this case.
All right. Surgery from the panels, surgery? No, it's we are all the interventionists, right?
I don't want to break the party, but is this true left main, or is it just a very short left main, and essentially it's Prox LAD and ostial circ? It's like an equivalent of left main, so it's not.
Very short left main.
yes, and we're gonna show us the
Okay,
iris
right.
and shortly, and so and we are put the three guidewire after hot team discussion. A relatively young age patient want to treat the PCI, and put the three wire in the major branch, and our routine is evaluate the nearly 100% imaging guided PCI for the case, and this is a total full evaluated from the distal LAD and the left main and the ostial. The plaque was absolutely extended to the left main, and the left main combined and the huge plaque. Also, we evaluated the sock and from the distal to the left main, and you can see the very tight sock ostium was plaque was extended left main, and this is absolutely relatively short left main the segment. And also we evaluated the high diagonal branch and the vessel size at least 3.0, and this is could be a reference for a proper stent selection, and the diagonal branch ostium also severely compromised, and then the short left main, and we decided to treat and all the vessel and the crush technique. And initially, we are pre-dilation the sock and aggressively, and then pre-dilation the diagonal branch using the compliant balloon 2.5, and the immediate post balloon angio showing the branch ostium was compromised, and the left main was the short left main artery. And first, and we put the diagonal stenting and the aggressive high pressure dilation. We put the Ultimester 3.024 diagonal branch, and then we fully dilated the non-compliant balloon at this moment, and then the first balloon crush and the LAD balloon crush. And then we moved to the sock and the distal part, put the Ultimester 3.0, and the proximal part, the Ultimester 3.5, and then we do very aggressive high pressure balloon, and the prior first high diagonal branch initially balloon crushed, and then after high pressure balloon, and we do a balloon crush and the high diagonal branch and the sarcoosteum. This is using the approximate part 4.0 non-compliant balloon, and then we put the LADs, the long stand 3.5, 38 ultimaster, and then finally we put the left main stenting. We try to cover the left main ostium, and 4.0 28. We do aggressive high pressure ballooning using 3.5 and the 4.0 high pressure ballooning. And the first we balloon crush, and then we put the stand and the high pressure ballooning. And we do sequential kissing balloon dilation, the diagonal branch using 3.0 non-compliant balloon, LAD 3.5 non-compliant balloon. This is the first kissing balloon dilation. And then we try to, there is some skip zone in the diagonal ostium and the LAD part, and we try to the kissing balloon and the left main and the sarcoosteum using the 3.5 non-compliant balloon. And this is the epicranial view. We can see the LAD opening is good, and the left main is fully extended well, and also evaluated, and the sarcoosteum was fully expanded. We can see Yves, and the sarcoosteum is coming here. It's widely open, nearly one strut carina. Also, we evaluated high diagonal branch is expanded well, and this is just one strut carina. Ostium is well open, and this is the final angio, and this is the RAO coral view. We put the stand one diagonal branch, two circle branch, two LAD, two left main, and 5 drug loading stand. This is the final, the spiral view, and you can see and remind that this is the first diagonal, first spiral angio. This is the final result angio. Is you can, very difficult to find some loss of the side branch. All side branches are patent and arrive, and just the loss of some septal branch, and the patient result is excellent, and the patient is doing well in our regular outpatient clinic. So, and this is my last summary, the key message of complex left main PCI. This is our routine ASAN PCI practice, and best revascularization should be discussed in hot team discussion. And the imaging guided PCI was effective than angio guided PCI, especially for complex PCI, including the main and the chip bifurcation. This is a confirmed, recently renovated complex PCI trial published in New England Journal of Medicine. Yves in the intravascular imaging OCT or Yves is fundamental for complex left main PCI and should be considered as a standard of care in the contemporary PCI practice. Thank you for your attention.
So we're going to do a discussion case by case. I think it'll be better. So maybe I can ask Yves to take this. So two stent approaches in this left main. Is it the French way or?
Yeah, we need two stents, but I would say it can be done a different way. You know, for example, you can do left main to LAD 3 wires, circumflex, diagonal, and distal LAD. Do a long stent with a possible large extension in the left main, so you have to choose a stent. After that, you do an access to the circumflex, you exchange a wire, you do a kissing and you put a stent. You put a stent and you do a kissing, and you do the same in diagonal. So you do a double stenting on both the bifurcation, but this is beginning with the main vessel. So this is possible. People think it's difficult, it's not.
I have questions. The details. Thanks for the good case sharing. So already Dr. Dimitrios mentioned this. I think angiographically, this left main is, I think, a 001 within a classification on also is the proximal LAD and diagonal bifurcation lesions is based on the angiographic analysis. But you evaluated the Yves, so some classification is changed.
Yes,
right?
yes. This case was changed. You know, By angiographically, it looks like a 0,110, something like that, but we're gonna use the intravascular ultrasound. I guess approximately more than 1/3 could be changed by IVC evaluation. There is a huge plaque burden and the lumen area was narrowed. The reason why we should do imaging-based PCI, especially for complex anatomic disease.
Thank you. So we can now move to the next case, Dr. Sripal, Bangalore, that will present the MultiVessel PCI case.
Thank you very much. When I saw the agenda, I was wondering like which of the MultiVessel should I actually present. So what I decided to do was go along with the theme of what I did in terms of my talk. Just a quick thing for Dr. Taggart. I mean, based on his comment, I can tell you that I have a very busy PCI program. I'm the director of the CTO program. I haven't had a single patient so far who said they don't want PCI because I did not promise them a survival benefit. I mean, that being said, I haven't seen any change in the volume, mainly because we are treating symptomatic patients. But anyway, so this particular patient, 63-year-old guy, he presented with severe ischemia. We'll come back to that part. Multiple risk factors, hypertension, hyperlipidemia, diabetes, family history of CAD, ex-smoker, no angina, but he endorses occasional dyspnea on exertion. I mean, this is also not very consistent, but periodically dyspnea on exertion. His blood pressure is, as shown there, 138/74. His BMI is around 26. These are some of his labs. His HDL is on the lower side, 37, LDL of 53, HbA1c of 7.2, and you can see his medications, aspirin, atorvastatin at 20. He's on some diabetes medications, metoprolol and lisinopril. He was referred for a nuclear SPECT, and this is what the SPECT showed. As can be seen here, so he has reversible anterior apical ischemia and maybe some inferior reversible ischemia also. And of course, more about the nuclear SPECT here, reversible anterior apical and some inferior ischemia. Some stress score of around 20. So he does have a decent amount of ischemia. So he has severe ischemia. So maybe, since the panel wants to be interactive, so this is a guy, no symptoms, occasional dyspnea on exertion, multiple risk factors. What should we just do for this patient? And he has severe ischemia on stress testing. Should we just optimize medical therapy? Should we do a coronary angiography and just send him for revascularization? Maybe given that he is diabetic, maybe consider cabbage. Should we do a coronary CT or do we put him on a treadmill and really assess whether he has no symptoms?
I think you've got to rule out left main disease and then decide what you do, whether it's medical therapy or revascularization.
Okay. So great point. So that's this patient had a coronary CT at this point. So this is coronary CT. The reason it looks different, I'm sure Jim Min is going to speak at this session, I think either today or tomorrow. This is automated assessment of lesion severity on a coronary CT. As you can see here, he has 3 stenosis. This is interesting in terms of the depth of information this provides. He has 3 severe stenosis. He has a total plaque burden of around 1,200, of which 358 is calcified plaque volume and 900 plus is non-calcified volume. And what we can see here is severe stenosis of his proxial AD, CTO of his D1, D2. This circumflex is read as moderate to severe, and his mid-RCA is also read as moderate. So now we have some definition of anatomy, no left main disease, again, and multiple risk factors, no angina, shortness of breath, severe triple vessel disease. What should we do next?
I would have an honest discussion with the patient. I think both options are reasonable, and it comes down to shared decision-making with the patient. There are no absolutes here, I think.
Have you quantified the volume of ischemia?
Yeah, he had, I think, around 12% ischemia.
I guess part of it's going to be whether you really believe this gentleman has triple vessel disease and therefore is prognostic, or whether he has, functionally 1 or 2 vessel disease, because the way I would manage it would be very different in those 2 cases.
No, absolutely. So I think those are all a great consideration. So this was a patient who was enrolled in the ischemia trial and interestingly was randomized to the conservative strategy. So, I must point this out. So I think if we had done the trial where we did angiography on anybody, on all patients and randomized them post-angiography, I'm just curious from the audience, how many of you would have randomized this patient? If you knew that this is a diabetic triple vessel disease, after seeing the anatomy, would anybody have randomized this patient in the trial? Anybody randomizing this patient to the trial? So, that's one of the reasons why we did the trial the way we designed. It was coronary CT, the sites were blinded, so they did not know this patient had triple vessel disease. The only thing they knew was this patient did not have left main disease. So this patient was randomized to the conservative strategy, so we followed our OMT algorithm. He did not have angina, so there was no escalation of anti-anginal therapies. Lipid lowering, his LDL is 50, but his HDL is somewhat low. His hypertension therapy is still not at goal, and his HbA1c was 7.2. So there was, and the main thing which was done was to counsel him on behavioral risk factors, increase his physical activity, diet counseling, etc., and add on SGLT2, GLP receptor antagonist, etc. So these were his follow-up. His blood pressure was reduced with some of these measures. HDL improved. I suspect it's mainly because of increase in physical activity, etc. His HbA1c decreased with the use of other medication. His statin dose was increased. So in terms of follow-up, this patient has been doing well for over 7 years of follow-up, no symptoms, no events. He follows up. The one critical component for this particular patient is he follows up regularly. I think this is a critical component because we had told him if there is any change in your symptom status, we will talk about your options, and he has been compliant with medication. So just to summarize, what we've seen from all of the trials is reasonable to consider medical therapy. The critical component is close follow-up and consider cath and revascularization as needed. Many a times we start debating about revascularization versus medical therapy as if it's black or white, but in reality, we are following these patients very closely and changing therapies as needed. And again, as was told by the panel here, important to rule out left main disease. Honestly speaking, if I had a patient like this today, I would also consider upfront a cath and revascularization because there is a small reduction in cardiac death. There is reduction in spontaneous MI, unstable angina, and cardiovascular stays. And if he had any symptoms, we would consider that. But I think personalized treatment decision is important. And I think the key is counseling these patients based on evidence-based benefits and risk. Thank you for that.
Is there a follow-up CT angiography in these patients in the part of the study?
No, it's not part of the study. Now we are in the extended phase and the patients can undergo whatever they want, coronary angiography or CT, etc. But there is no follow-up CT.
So for this very specific patient, so I think that the patient prognosis may be determined by the progress of the circumflex or right coronary artery disease. And the patient already have a very severe ischemia in MPI. So I think in this patient's medical treatment and the role of follow-up CT scan is very important because if you see, even without symptom, if you find the evidence of progression of circumflex or right coronary artery, PCI may be definite, or revascularization is definitely needed. So that how do we follow this patient up, except for the good medical treatment and symptoms? So how do you think about the role of outpatient functional test or anatomical test in this patient?
Yeah, so I think in terms of, we need more data, definitely, in terms of what to do. I'm not a big fan of functional testing because that has its own limitations, especially if you have multivessel disease. We may be falsely assured that the stress testing is normal and negative. And in terms of follow-up CT angio, again, this patient does have some calcification, so there are challenges there. I think the key is to make sure all of the numbers are moving in the right direction, the LDL, HDL, blood pressure targets, and I mean, he's not curtailing his symptoms and so forth. I mean, one thing that I also must point out is, when we define anatomy, we try to place them at a higher risk, but there are multiple of these patients walking around. I mean, they have no symptoms. Nobody is doing a screening angiography for these patients. So we may have patients who have triple vessel disease walking around, and many of us are comfortable just managing the risk factors.
David Taggart, I mean, you're the surgeon. What's your view here? I mean, should this patient be going for surgery?
Absolutely, yes. And I think this illustrates the problem when patients are not discussed by a multidisciplinary team. Here's a 63-year-old man, diabetes, severe 3-vessel coronary disease. The guidelines tell you this man should have CABG. Now, if you're telling me you spoke to the patient and said, all the best evidence suggests that you should have bypassed grafts, but the patient then said, no, I want to enter your ischemia trial, I would find that difficult to believe. But to me, this illustrates the kind of problems we often see. Here's a patient with classic indications for CABG. The guidelines tell you that's what you should have. The FREEDOM trial showed you this is the very type of patient who has a much better long-term survival with CABG, and yet he still ends up not getting that appropriate treatment. So I find it difficult to follow the rationale. Thank you.
Okay, thank you. Really good. ISCHEMIA. All right, Spencer. All right, Spencer.
Let me just say one thing. Dr. D.W. Park is talking about how, yes, the evidence many of you shown has put surgery in front on many of these issues. And now, but the issue is, has PCI gotten so much more sophisticated that now it can challenge surgery? And you're talking about a trial. Where'd he go? But Dr. Park's trial interests me because you showed the endpoints. One of them was myocardial infarction. And I just want to know, what is that? Is periprocedural infarction going to be in it or not? Because I think here we'll be in the same conundrum. We'll have Dr. Taggart up here railing against PCI again, unless we get this straightened out in front.
Yeah, and even in the DEFINE DM trial, we try to include periprocedural MI, and as Spencer mentioned, there's still big controversy about the definition of the periprocedural MI, and I know the ARC3 consortium is trying to develop some relatively fair definition of a periprocedural MI, and in the near future we are available much, is it Bangalore? Do you have any comment?
I wish you could leave periprocedural MI totally off the table, but that's my view.
Yes, thank you.
Thank you. So we're gonna move. Next case is bifurcations. Do Yong-Gang from Assam Medical Centers.
Yes, I am Do Yong-Gang from Assam Medical Center. I share my case of the non-left main bifurcation, much simpler than previous cases. For non-left main bifurcation, everyone says provisional. Subprime myocardium is small, it is not associated with a survivor, and ESG guideline recommends provisional as 1A. However, there is small exceptions in guideline. Upfront side branch stenting may be preferable when large side branch diameter with a long ostial lesion, and anticipated difficulty in assessing side branch after stenting main vessel. That means high risk of acute side branch occlusion. This is a 73-year-old male patient that I met my second year of the independent operator. And the patient visited the clinic of the effort angina since 2 months ago. He had a history of diabetes, hypertension, AFib, and underwent RFCA 7 years ago, and now sinus rhythm. I checked the CT, and CT showed the mid-aerated severe stenosis. I did the angio, and mid-aerated shows intermediate stenosis, and measured FFR, and it was 0.70. So I began to PCI, and I did not keep the wire in the diagonal. And after crossover, you can see that the diagonal branch flow is slow. And the patient, the symptom is not so severe, just mild chest pain. But I wanted to open the diagonal branch, and I tried, and I called my senior and another senior, and we did it for 1 hour, but we could not. And after that, the patient symptom is tolerable, and there is slow flow ongoing, and so I finished the procedure. After the procedure, there was a procedural MI with a CKMB elevation up to 100 and troponin up to 67, and just discomfort persists, but a little bit relieved, then discharged 2 days after the procedure. And the medication was up-titrated. EKG was normal. However, the patient still have the persistent default angina, and the patient says that symptom is worse than before PCI. And it took 1.5 years that the patient do not blame me. And after that, now the patient is okay. Maybe there was some collateral growth. And the role of PCI in stable ischemic heart disease is for symptom control. So in this case, I failed to control his symptom. The patient does not die, but the patient still have the severe symptom. And so as Dr. S.J. Park said, the front two stent for large side branch with a high occlusion risk. And when there is a risk of inadequate symptom control, I think the upfront approach or the protection of the wire or balloon is needed. And Dr. Koo elegantly demonstrated that what is the important side branch angina, EKG change, ischemic potential would be the cause of the important side branch. And after balloon occlusion, the diagonal branch with a larger vessel size more than 2.5 and small 1 or 2 diagonal branch only in LAD and no branch below that made ST elevation when occluded with a balloon. Then those kind of branch will make symptom if occluded. So in those cases with a big side branch, and we will expect to have to rewire, and in this kind of case, to avoid pain during and after PCI, upfront stenting can be justified, I think. And now, because the outcomes of the two stenting in even non-left main bifurcation has been improved in the second generation stent era, I can recommend those approach. And while protection is needed if you do not want to upfront two stent, they don't make the complicated situation for stable angina patient. In this case, large diagonal branch was gone. And we need a long time to open the diagonal and make some dissection and the provisional stenting. It took some time, energy, and patient had chest pain and peripheral MI. Sometimes simple crossover is not simple. So in those cases, the upfront two stent or the more aggressive protection of the side branch is needed. In conclusion, non-left main bifurcation, yes, provisional approach is standard. Side branch occlusion is not associated with the increased mortality. However, we should consider upfront two stenting in patients with a high risk of the large side branch occlusion, expected inadequate symptom control. Thank you for your attention.
Thank you.
So I have two things to tell you. First, when you are dealing with a bifurcation, you have to put a wire in the side branch. Always, because the first case you did was not an easy approach of the side branch.
Yeah.
Maybe this is the reason why you didn't put a wire there. But it's difficult to go. Then you occlude is even more difficult to go.
Yeah.
And the second point, I have seen two occlusions of the diagonal branch, and they were both related to two big stents with a single diameter, not a double diameter. You have to choose your stent from the distal diameter. I don't know how you selected your diameters, with distal diameter, and then do a pot. And after that, you keep your side branch patent. And a third point is when you put a wire in the side branch, you know where is the side branch when it's occluded. It helps to keep the side branch patent, has been demonstrated in a work in Korea. and is also changing the access angle to the side branch. So I mean the difficult access of the first patient would have been completely modified by the presence of wire in the side branch. So I think this is this provisional strategy were not well performed, and this is not a reason to consider double stenting beginning with the side branch.
Great. Basically, not too much difference, right? However, you changed in our lab, and so every time I told them, don't touch. So the reason why, right? So the reason why
don't touch. I agree with you. Don't touch. Don't touch. But don't lose the side branch.
So from the
all right.
our
Even in those cases, don't touch. Right? So, all right. You're gonna move. Last case is Jung-Min, the CTO. Is it really we have to do that?
Thank you, SJ. I'm Jung-Min from Assam Medical Centers. Actually, I'm not master for CTO. This is my disclosure. So we have a lot of CTO device, and then we had the many CTO algorithm. Due to the CTO intervention, our PCI procedure technique has been improved. So I'd like to share my past CTO case. The 63-year-old ejection fraction is very low, triple vessel CTO. So because of high risk, I did step-by-step for 3 days. I opened the oral CTO. So I spent a lot of time and many stents, balloon, and contrast procedure time is very long. Another CTO is like this. RCA total occlusion, the antegrade failed and retrograde. And final outcome is very nice, but I also spent a lot of time and stents, balloon, etc., etc. So why I opened the CTO? Because I thought opening CTO, I thought was associated with the better patient survivor. But this data is based on the comparison between the successful PCI, successful CTO PCI, and failed CTO PCI. The successful PCI is associated with a better survival than the failed CTO PCI. Then we have to consider that successful PCI increased the patient survivor or failed PCI decreased the patient survivor. CTO is inherently stable, and ISCHEMIA trials show that no benefit of PCI over medical treatment. So I think previous observation study have to interpret it like this: failed PCI, failed CTO PCI, decreased patient survivor. Because the many CTO registries show that the CTO PCI is associated with the high risk of complication. So now we have 2 random trials to evaluate the clinical outcome with the moderate side. The decision CTO showed that up to 4 years, clinical outcomes no difference, CTO intervention or medical treatment. In addition, neuro CTO showed that even though improved the patient symptom, but 3-year follow-up showed that mortality is even higher in PCI, CTO PCI group. So some small group random trials show that the CTO intervention did not improve the ejection fraction and wall motion abnormality. Previous very old study, OAT study, total occlusion after infant-related artery, PCI did not improve the patient survival. The last year revived PCIs. I think many CTO was included in this study, failed to show the survival improvement. So 2 years ago, US guidelines show that I was surprised to read this sentence: in patients with suitable anatomy who have refractory angina on medical therapy after treatment of non-CTO lesions, benefit of PCI or CTO to improve symptom is uncertain, actually uncertain. So present, my thought is data in favor of CTO are entirely for symptom relief. CTO PCI was not associated with the improvement of survival or clinical outcomes. Non-CTO would be more relevant and safer target for symptom relief. This is our recent patient, LAD CTO. LAD is very flexible CTO. Patient complained of very minimal effort chest pain. I thought left main, this left main is the main target culprit for the patient symptom, I just simply crossover from left main to cell complex. I didn't try the LAD CTO intervention. Fortunately, the patient is doing very well without angina after procedure. Then what is next? Some registry show that the reduction of ischemia after CTO intervention is associated with better survival. So like a ischemia trial, 2 ongoing trials, ischemia CTO trial, novel CTO trial, including the inclusion criteria of functional study. If these studies show the favorable outcomes of CTO intervention, I will consider the LLD CTO intervention in the future for previous cases. Thank you for your attention.
This is exactly what I was asking Dr. Ziad earlier. I mean, you've got, we're so uncomfortable leaving CTOs, like an LAD CTO was left here, but actually these patients may do very well with fixing the non-CTO lesion and then seeing how they do. But it is an antithesis to what we've been trained to do all these years.
Well, I have a request. If I have an angiogram like this, please fix my LAD. or do a lima or something. Don't leave my LAD occluded. I mean, let's raise hands. Who would want to have his LAD or her LAD left like this? Anybody? So why are we arguing? If you don't want to have your LAD or your dad's LAD left alone like this, with a stent or with a lima, I have nothing against lima, Dave. So I really don't see the point of debating.
I mean, I guess the question that I think is important and valid to Dimitri's point is, in young patients, as there's progression of atherosclerotic disease, now if this patient's developed right coronary artery disease as well, now you have a much larger burden of ischemia, much larger territory at jeopardy, and we know when you have more jeopardy, that is when you actually have a potential survival or MI benefit.
But at the same time, we may be in the midst of a paradigm shift where what you're saying is absolutely what we all think. LAD, don't leave it alone. But maybe that's not true because the evidence is not bearing out what we've always thought, that you don't leave an LAD like that, which is exactly what Dimitri just said.
I just don't know what's the trial or the design of the trial that would answer this question. There are much smarter people and trialists than I am on the table and in the room. What trial do you want? For how many years are you going to follow these patients? I have a very large practice, and I see patients with neglected CTOs, and then they come with blown hearts. Who tells you that this patient in 5 years will not come back with an EF of 30%, and then you're dealing with a completely different problem? And again, randomized trials are great because we don't have anything better than that. It's like democracy, right? It's the best, it's the least bad of all the options that we have, so we follow them, but we should not turn it into a fetish and go just by randomized trials. They don't answer all the questions. They don't include all the subcategories of patients. And that's where the art of medicine comes into play and making some decisions.
I mean, if, in fairness to what Dimitri's saying, if this was a 99% lesion, nobody would leave it. Nobody.
But the biology is different. The biology of a 99% lesion is different from a CTO. I mean, we've all seen people.
Why do you say that?
The biology of 299% lesions is different. A calcified stable is not going to give you a plaque rupture. Another one with soft core would give you an MI. So the question I ask is, if you can tell me that a cell that is sitting in the apex of the LAD, a myocyte of the left ventricle, understands if upstream there's a 99 or 100, does the myocyte know?
I don't. Oh, sorry. No, I am a bit surprised not to hear any viability testing, viability of myocardium in CTO. In our place, for any CTO, we are sending the patient to MRI, stress MRI and viability MRI. So we can judge if this supported myocardium is viable or not. So and we can even decide to treat patients who are not symptomatic. Why? Because they have a left ventricular dysfunction. I remember several cases like this. And looking at the viability, was perfect. Not always, but sometimes the contractility improved. So I think looking at the viability is really, for me, essential.
But Yves,
Go ahead.
Sorry, in Revived, that didn't pan out at all.
Or Stitch. I mean, in
Right?
Stitch, there
So
was...
the viability had like literally no impact. I'm not arguing with you, but I find that
Viability
interesting.
in the territory of the occluded vessel, of course. But,
Yes. So the best data that we have for viability comes from Stitch, and these are not good data. They were all over the place. In PROTECT 4, there is a sub-study that we do MRI pre and post at 6 months, and we are blinded on the viability results. And I think this may answer the question of what happens when we revascularize viable versus non-viable myocardium. So this is a sub-study of about 240 patients, and I think it's going to give us the best, at least PCI data regarding viability. So maybe next year or in 2-3 years, we will discuss the results of viability.
David, you wanted to give a point.
David?
I mean, I do think it's, I want to challenge Dimitri a little bit, and not just because Dimitri was my fellow and whatever he's saying, it must be what I taught him a long time ago. For it, I mean, just because you wouldn't want your LAD to look like this doesn't mean that that's better. It just means that's what your opinion is, and you have no data whatsoever to support that. So I think I think we have to just have some humility about what we don't know in this field. And I don't know that treating this patient's LAD, especially with CTO PCI, is going to prolong their life, which is the only reason you're doing it, because they don't have any symptoms. We just, we heard that. So I think we have to, again, be very humble in what we assume. And I think if you really want to, you think you're going to save somebody's life by doing an LAD CTO PCI, send them to David Taggart and let him put a limit on there that's going to stay there. But but that was not your first choice. That was an alternate. I mean, I think if you want to, something that's going to last this young woman, the next 40 years, it's not a PCI of their LAD. It's a lima, and you might as well just let David, have his fun and do one case.
Well, let me challenge you, since you were my attending and you taught me everything I know. So first of all, I said that we don't know and that we need the trial but if you have an idea of a trial that will prove or disprove this concept, please enlighten us. The second thing I said is that I'm not going to say anything else.
I think the final word from Spencer, and we'll close the...
No, David may think you learned everything from him, but you learned everything you know at Emory. And at Emory, you would not ever randomize such a patient to opening the circ versus putting a lima to the LAD, bypassing,
exactly.
CIRC, which would be so you can design a trial to measure that if you want to, but you'll never get a patient randomized.
All right, we have limited time, as I would talk with Dr. Bangalore, but okay. Single vessel proximal LAD disease actually is not related with the survival, is that right? Single vessel proximal LAD region is really related with the survival?
No, at least not from trials.
All right, so based on the data, we can guess, the last case Dr. An showed that one. Proximal LAD, 90% stenosis, and 100% CTO lesion, which one is more stable? But for the patient, for the long term, single vessel itself, even in the proximal LAD, CTO lesion could not relate to the long term. However, 80% stenosis is more vulnerable, future perspective, rupture, something like that. However, CTO lesion, chronic, process of total lesion is more safe. Actually, in many cases, you just prox-LED CTO, normal myocardial perfusion scan, prox-RCA CTO, good collateral, normal myocardial perfusion scan, no symptoms. Actually, we don't need that, any, revascularization for that. So, all right, so we need more data.
I haven't seen a proximal LED even with collaterals the size of the pen that it's not ischemic. And that has been proven
All
many.
right, we have many cases. All right.
So
All
let
right,
me ask you
so
something.
anyways, it's, all right, we're gonna discuss it later, but, really, this is the first session in our, TC 2023. Really happy to, join with you all, and so thank you for that. We're gonna move on.